Indication: BESREMi is indicated for the treatment of adults with polycythemia vera. Important safety information. Warning: risk of serious disorders. Interferon alpha products may cause or aggravate fatal or life-threatening neuropsychiatric, autoimmune, ischemic, and infectious disorders. Patients should be monitored closely with periodic clinical and laboratory evaluations. Therapy should be withdrawn in patients with persistently severe or worsening signs or symptoms of these conditions. In many, but not all cases, these disorders resolve after stopping therapy.
Hello, I'm Dr. Firas El Chaer. I'm a hematologist in Miami, Florida, specializing in myeloproliferative neoplasms, including polycythemia vera or PV. This field has changed dramatically in recent years. For a long time, patients had limited options. But today, we're seeing real progress with new therapies and an increased focus on clinical research. It's an exciting time, and I think these patients truly benefit from more targeted care. In PV specifically, our treatment approach continues to evolve. We're moving beyond short-term hematocrit control and taking a more comprehensive, long-term approach for disease management. In clinical practice, that means choosing therapies that can deliver sustained control over time, reduce phlebotomy burden, and address the underlying disease to offer long-term benefit. BESREMi reflects this shift, supported by the result of the PEGINVERA and PROUD continuation PV studies. By targeting the source of PV in the bone marrow, BESREMi achieved high rates of complete hematologic response and phlebotomy-free control over years. Before we turn to the results of PROUD continuation PV, let's review the pivotal PEGINVERA study of BESREMi. The PEGINVERA study was a multi-center, single-arm trial conducted to evaluate the dosing, tolerability, and efficacy of BESREMi in patients with PV over 7.5 years. In this study of 51 patients, BESREMi achieved an 80% complete hematologic response rate, defined as no phlebotomy in the past 2 months, hematocrit under 45%, a leukocyte count under 10,000, and a platelet count under 400,000. 61% of patients achieved comprehensive disease control, defined as no phlebotomy in the past 2 months, hematocrit under 45%, a leukocyte count under 10,000, a platelet count under 400,000, normal spleen size, and an absence of thromboembolic events. In terms of safety, 95% of adverse reactions were grade 1 or grade 2. The most common reported adverse reactions were influenza-like illness, arthralgia, fatigue, and pruritus. As we know, sustained disease control is critical in PV, as it may help reduce the risk of thrombotic complications. With that in mind, I'll take you through the data from the PROUD continuation PV study. Before we get to the results, let's review the study design. The PROUD continuation PV study assessed long-term use of BESREMi. PROUD PV was a 12-month, phase 3, open-label, randomized non-inferiority study comparing BESREMi with hydroxyurea in adults with PV. Continuation PV followed patients who completed the PROUD PV study for more than 6 years. To be eligible for continuation PV, patients had to complete PROUD PV and meet one or more of the following criteria: normalization for 2 of 3 blood parameters if parameters were increased at the PROUD PV study baseline, a greater than 35% decrease in 2 of 3 blood parameters if parameters were increased at the PROUD PV study baseline, normalized spleen size, or any other clear benefit from BESREMi. Patients were stratified by age, prior thromboembolic events, and prior hydroxyurea. Let's look at the starting doses for PROUD PV, then continuation PV. In PROUD PV, the starting dose for BESREMi was 100 micrograms subcutaneously every 2 weeks for cytoreduction naive patients, or 50 micrograms every 2 weeks for those transitioning from hydroxyurea. The dose could be increased in 50 micrograms increments every 2 weeks up to a maximum of 500 micrograms until a complete hematologic response was achieved and maintained, consistent with the FDA-approved prescribing information. The starting dose of hydroxyurea in PROUD PV was 500 milligrams per day. Patients on hydroxyurea at enrollment continued with their enrollment dose. The dose could be increased in increments of 500 milligrams until complete hematologic response was reached and maintained. There were no significant differences between patients who entered the continuation PV study and those who did not roll over. In continuation PV, BESREMi dosing started at 50 micrograms every 2, 3, or 4 weeks and was administered subcutaneously. The dose could be increased in increments of 50 micrograms every 2, 3, or 4 weeks up to a maximum dose of 500 micrograms until complete hematologic response was reached and maintained. The control group in continuation PV received best available treatment. 88% of patients remained on hydroxyurea at month 72. Next, let's focus on the endpoints. The continuation PV study had co-primary endpoints. The first primary endpoint was complete hematologic response, defined as hematocrit under 45% without phlebotomy in the past 3 months, platelet count under 400,000, and leukocyte count under 10,000 with normal spleen size. The second was complete hematologic response and resolution and/or clinical improvement of disease-related signs, clinically significant splenomegaly, and disease-related symptoms, which were microvascular disturbances, pruritus, and headache. It's also worth noting some study limitations. The primary endpoint of PROUD-PV study was a composite outcome of complete hematologic response and normal spleen size by imaging at month 12, which was not met. 21% of patients treated with BESREMi achieved the composite primary endpoint, compared with 28% of patients treated with hydroxyurea. PROUD-PV provided critical insight into the time-dependent activity of BESREMi, leading to the continuation PV extension to assess whether responses deepen and are sustained with longer treatment. Initially, continuation PV was designed as a single-arm extension of PROUD-PV to evaluate the long-term safety and efficacy of BESREMi. Later, a second arm was added for comparison that included either hydroxyurea or the best available treatment. Patients entered the hydroxyurea best available treatment arm significantly later, after approximately 21 weeks. It should be noted that since patients were not initially scheduled to take part in continuation PV, not all patients continued to participate in this study. Not all patients received only hydroxyurea in the comparator arm. Some patients received best available treatment. Now, we can dive into the efficacy. In my practice, it's not just about hitting the correct numbers. I want to see a response maintained over multiple years. PV is a chronic condition, and we want to prevent thrombotic events and complications long-term. BESREMi has demonstrated this long-term efficacy in the PROUD continuation PV study. As you can see here, BESREMi delivered high rates of complete hematologic response over time. Complete hematologic response was achieved and sustained across multiple years. 77% at 3 years and 73% at 5 and 6 years. And by controlling all blood counts, you can also reduce the need for frequent phlebotomies for your patients, which may be disrupting to their day-to-day life. In the PROUD continuation PV study, BESREMi delivered high phlebotomy-free rates sustained over multiple years. 78% at 3 years, 83% at 5 years, and 81% at 6 years. The phlebotomy-free rate was defined by the percentage of patients in which no phlebotomies were required to maintain hematocrit below 45% among those with available data for each treatment year. When treating patients with PV, it's not enough to control hematocrit. My goal is to normalize all 3 blood cell counts. Persistent leukocytosis puts PV patients at higher risk for thrombotic complications. In this study, patients treated with BESREMi achieved a lower leukocyte count from baseline. At 72 months, there was a reduction of 6,670 in the BESREMi group. In the control group, a reduction of 3,590 was observed. Those in the BESREMi group were also observed to have normal leukocyte counts for a mean proportion of time of 94%. In the control group, the mean proportion of time in response was 81%. Further analysis of this study has been done, including a post-hoc analysis of the probability of event-free survival. In this analysis, the probability of event-free survival was high in the BESREMi group, with events defined as thromboembolic events, disease progression, and death. Notably, separation of the event-free survival curves became apparent by approximately month 24, and was sustained through long-term follow-up. BESREMi showed a probability of event-free survival through 90 months of 94%. The control group demonstrated a probability of 82%. Overall, risk events, including thromboembolic events, myelofibrosis, and death, occurred in 5% of the BESREMi group. Risk events occurred in 16% of the control group. This translated to a 67% reduction in the probability of experiencing an event for patients on BESREMi. Now let's review the safety results. In my experience, patients generally tolerate BESREMi well over the long term. And that's what we see from this study. Comparable rates of grade 3 or higher treatment-related adverse events were observed between the two groups, about 16% with BESREMi and 17% with the control group. PV-associated adverse events declined during long-term treatment with BESREMi, occurring in 7% of patients at year 6 compared with 12% of the control group. The most common treatment-emergent adverse events observed in patients on BESREMi at 6 years were thrombocytopenia, gamma-glutamyl transferase increase, and leukopenia. In the control group, the most common treatment-emergent adverse events at 6 years were thrombocytopenia, anemia, and leukopenia. Let's look at common adverse reactions from a pooled safety population of the PEGINVERA and PROUD continuation PV studies. This represents 178 patients with PV who were treated with BESREMi monotherapy. In this pooled analysis, the most common adverse reactions reported in over 10% of patients were liver enzyme elevations, leukopenia, thrombocytopenia, arthralgia, fatigue, myalgia, and influenza-like illness. I always talk to my patients about possible side effects and have a plan to address them. In my experience, patients can often continue on BESREMi while managing low-level side effects. PV is a lifelong journey, and every patient deserves more than just short-term control. As the data from the PROUD continuation PV study show, BESREMi delivered sustained complete hematologic response, phlebotomy-free years, and normalized leukocyte counts. In a post-hoc analysis, it even showed improvement in the probability of event-free survival. For my patients with PV, I trust BESREMi to help manage their disease today and provide the cytoreduction they need for the future.
Indication: BESREMi is indicated for the treatment of adults with polycythemia vera. Important safety information. Warning: risk of serious disorders. Interferon alpha products may cause or aggravate fatal or life-threatening neuropsychiatric, autoimmune, ischemic, and infectious disorders. Patients should be monitored closely with periodic clinical and laboratory evaluations. Therapy should be withdrawn in patients with persistently severe or worsening signs or symptoms of these conditions. In many, but not all cases, these disorders resolve after stopping therapy. Contraindications: existence of or history of severe depression, suicidal ideation, or suicide attempt. Hypersensitivity to interferons or any inactive ingredients. Moderate or severe hepatic impairment. History or presence of active serious or untreated autoimmune disease. History of transplantation and receiving immunosuppressant agents. Warnings and precautions. Depression and suicide. Closely monitor patients for any symptoms of psychiatric disorders and, if needed, consider psychiatric consultation and treatment or dosage modifications as listed in the full prescribing information. Endocrine toxicity. Do not use BESREMi in patients with active serious or untreated endocrine disorders associated with autoimmune disease. Evaluate thyroid function in patients who develop symptoms suggestive of thyroid disease during BESREMi therapy. Discontinue BESREMi in patients who develop endocrine disorders that cannot be adequately managed during treatment with BESREMi. Cardiovascular toxicity. Patients with a history of cardiovascular disorders should be closely monitored for cardiovascular toxicity during BESREMi therapy. Avoid use of BESREMi in patients with severe or unstable cardiovascular disease or recent stroke or myocardial infarction. Decrease peripheral blood counts. Monitor complete blood counts at baseline, during titration, and every 3 to 6 months during the maintenance phase. Pancreatitis/colitis/pulmonary toxicity. Interrupt BESREMi treatment in patients with possible pancreatitis, colitis, or pulmonary toxicity and evaluate promptly. Consider discontinuation of BESREMi in patients with confirmed pancreatitis or who show signs or symptoms of serious ulcerative or hemorrhagic colitis, or who develop pulmonary infiltrates or pulmonary function impairment. Ophthalmologic toxicity. Advise patients to have eye examinations before and during treatment. Discontinue BESREMi in patients who develop new or worsening eye disorders. Hyperlipidemia/hepatotoxicity/renal toxicity. Monitor serum triglycerides, liver enzymes, hepatic function, and serum creatinine at baseline and during therapy. Avoid use of BESREMi in patients with eGFR less than 30 milliliters per minute. Discontinue BESREMi in patients with persistently marked elevated triglycerides, evidence of hepatic decompensation, or if renal impairment develops during treatment. Dental and periodontal toxicity. Patients should have good oral hygiene and regular dental examinations. Dermatologic toxicity. Consider discontinuation of BESREMi if clinically significant dermatologic toxicity occurs. Driving and operating machinery. BESREMi may impact the ability to drive and use machinery. Patients should not drive or use heavy machinery until they know how BESREMi affects their abilities. Patients who experience dizziness, somnolence, or hallucination during BESREMi therapy should avoid driving or using machinery. Embryo-fetal toxicity. Based on the mechanism of action, BESREMi can cause fetal harm when administered to a pregnant woman. Obtain a pregnancy test in females of reproductive potential prior to initiating treatment with BESREMi. Advise females of reproductive potential to use an effective method of contraception during treatment with BESREMi and for at least 8 weeks after the final dose. Advise women not to breastfeed during treatment and for 8 weeks after the final dose. Adverse reactions. The most common adverse reactions reported in greater than 40% of patients were influenza-like illness, arthralgia, fatigue, pruritus, nasopharyngitis, and musculoskeletal pain. Drug interactions. Patients on BESREMi who are receiving concomitant drugs, which are CYP450 substrates with a narrow therapeutic index, should be monitored to inform the need for dosage modification. Avoid use with myelosuppressive agents, narcotics, hypnotics, or sedatives, and monitor patients receiving the combination for effects of excessive CNS toxicity. To report suspected adverse reactions, contact Pharma Essentia at 1-800-999-2449 or FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. Please see full prescribing information, including boxed warning.